Okay, perfect. I think we're live now.
Great.
Hello everyone and welcome to this talk on haematological emergencies by Dr. James Clark. My name is Delphine and along with Sarah, we are the leads of the haematology team here at Minor Bleep. We're incredibly lucky to have Dr. James Clark with us today giving the presentation. Dr. Clark is a paediatric haematology trainee currently working at Great Ormond Street. Please add any questions you have during the talk to the chat, and if we have time at the end, we'll ask Dr. Clark to attend to these. So, James, if you want to start, then go ahead.
Fantastic. Thank you so much, Delphine and Sarah, for having me. Apologies for the slightly delayed start, everyone. So I've been asked to speak on haematological emergencies today. And haematology is a little bit of a black box for many people. So I want to make sure that if you have any questions, do ask them in the chat and I will try and address them. I'd much rather have a meaningful chat about one case than you to blitz over and not understand several. And also, I'd like to think if there's any cases that you've come across in your training or over the last few in medical school or anything like that you have any questions about and you wanted to delve into in a bit more detail, we can cover those at the end. It's always nice to hear your experiences and to try and understand those and reflect on those as well. Okay. So we're going to cover some urgent sort of complications and presentations of haematological conditions, looking at how they present and why they present, and look at the sort of emergency actions that need to happen and when to seek help. And that may be straight away, or it may be, but I want you to always know that although there is always heterogeneity in people's responses and everything else, haematologists as a whole are a relatively friendly bunch. We'd much rather hear about patients and say, that's fine, carry on, than not hear about them. So please always ask for help if you're not sure, okay? So we're going to look at a range of clinical cases. Now, I'm not expecting you to know the answer in any way, but I hope that you come away from this talk having a little bit more confidence with some of the sort of common presentations and things to look out for. Basically just headlines of, right, remember this, that's a big headliner to go looking for, okay? So our first case is a 54-year-old woman who presents with a new diagnosis of a high-grade lymphoma. And she received something called R-CHOP chemotherapy 7 days ago, and she presents to the ED, the emergency department, with a fever of 38 degrees Celsius. What complication do we anticipate? Now, I'm not going to suppose any haematological knowledge on anyone here, so do chip in if you have any thoughts. But a high-grade lymphoma is normally meaning it's a rapidly replicating haematological malignancy affecting lymphoid cells. And high-grade means it's normally quite aggressive. And so it grows quickly and needs treatment quite quickly, as opposed to a low-grade one, which is a bit more indolent and doesn't always need immediate treatment. R-CHOP chemotherapy is the standard sort of treatment for most high-grade lymphomas. And the worry, sort of 7 days in, is that it is quite myelosuppressive. So what that means is that the bone marrow is suppressed, meaning that they can become anemic, thrombocytopenic, meaning their platelet count is low, and also their white cell count can be quite low. And the differential there is, of the white cell count is that you have neutrophils and lymphocytes and a few others, but predominantly you have a neutrophil count, which is low, which is a neutropenia. So we're expecting them 7 days in until about day 14 to be neutropenic. So the thing we're going for here is that they are attending with febrile neutropenia, which some people use a shorthand of saying they're neutropenic sepsis. Now, the worry here, and forgive me for being a little bit more didactic in teaching, this is sort of, we can apply this in many ways, but virtual teaching is quite difficult to sort of go through these cases in sort of a backwards and forwards fashion. So in this circumstance, the worry is that they don't really have much of an immune system to speak of to fight off any form of infection. So what would be a relatively trivial infection is much more likely to be bacterial. And also that bacterial infection is much more likely to become disseminated and widespread. So a full-on septic picture as opposed to a sort of localized infection, because their neutrophils aren't able to sort of hold on to the infection to stop it spreading to the bloodstream. And so it can become life-threatening much more quickly. So this is one of the common things that we see in patients on chemotherapy, and we worry about it a lot. So whenever we counsel patients starting chemotherapy who we expect to become neutropenic, we will say to them, right, any temperature over 38, go straight to A&E, and many trusts will have a sort of a quick passport or a card or a letter that the patients will have and hand to the triage nurse saying this patient is on chemotherapy. You know, if they present with a fever, immediately give them, you know, triage them quickly, get the antibiotics in within a golden hour, because we know that that can save lives. And it's been demonstrated that the quicker you get antibiotics in, the quicker you can offset and mitigate that risk. So the first question here is, what antibiotics will you give? And this is very much trust dependent. Your trust will have a local neutropenic sepsis protocol or febrile neutropenia protocol. They'll call it one of two things. And obviously, just to clarify there, you can be neutropenic and febrile and not have neutropenic sepsis, but you treat as neutropenic sepsis, because if you have you can be febrile from a viral infection, and that won't be a septic picture, but you don't know at the outset where they're going. So you treat as neutropenic sepsis. And quite often you will give broad spectrum antimicrobials, including something like tazocin most commonly, and some gram-negative cover. And the rationale for that is where the bacterial infections come from. In neutropenic patients, the neutrophils actually have an additional role in maintaining mucosal membranes and maintaining the integrity of those, which is why neutropenic patients will quite often get oral mucosal ulceration, and they'll also get potentially some colitis type picture, where the gut mucosa is also less sort of protected and becomes quite frayed, for want of a better word. And that barrier that they normally have intact to encapsulate the bacteria within the gut is less intact. So you'll get what's called bacterial translocation. So the gut bacteria, which are most commonly gram-negative bugs, will translocate into the bloodstream or elsewhere and cause a significant infection. And you're much more likely to get gram-negative sepsis, and that comes with more likely to go into septic shock. So that's why quite often you'll have tazocin for broad spectrum cover with something like gentamicin or something similar to cover that type of infection to keep you safe. So that's why your protocols will incorporate that. When they come in, we want to know what they're growing. So you'll immediately treat down the sort of the old-fashioned septic 6 line, and you'll get some blood cultures off, but also you'll make sure you get all the cultures off that you possibly can. The worry here is that quite often you won't find a clear clinical focus. Sometimes you will, but because you don't have neutrophils, you won't get localization to where the bacteria is. So if they have a pneumococcus, you won't get a localized pneumonia because there's no neutrophils to form a focus there, so it becomes quite widespread quite quickly. So a chest x-ray quite commonly won't show a focus. Same for UTIs. You don't have neutrophils to on your urine dip to come up as a white cell positive, and if you have a non-nitrite forming bacteria, you won't get nitrites in your dip. So make sure you send off a urine as well for microscopy, culture, and sensitivity. Make sure in today's world you send off COVID PCRs and various other viral screens. Get the chest x-ray, even though it may not show anything. If there's lines, make sure that you get paired cultures from the line and from the peripheral blood so that you know where the infection is coming from, and you're going to treat them quite aggressively. Okay. The last question is a little bit loaded in the sense of when would you consider something called granulocyte colony stimulating factor. This is a subcutaneous injection that will stimulate granulocytes, normally to mobilize from the marrow to increase the peripheral circulating neutrophil count to allow you to the person to better fight off any infection. In this case, we've got a lymphoid malignancy, so it would be entirely reasonable if they are neutropenic to give them some GCSF if it's felt appropriate. There are certain caveats to that, such as Hodgkin's lymphoma and also specifically myeloid malignancies. So if you had a patient with something like acute myeloid leukemia, you would be very reluctant to give them that because it might just drive the underlying malignancy and make it worse. So you would potentially not be thinking about that in myeloid malignancies, which is why, if you're not sure, always have a chat to your friendly neighborhood hematologist. Okay? So hopefully that's a very common case that you probably will see very commonly if you're clerking in A&E, because these patients will quite commonly come through there, and it's just about making sure that you understand that there is a time sensitivity here to make sure that you get the appropriate cultures off and start urgent treatment. Okay, hopefully that makes sense. So we'll move on now to case 2, which is a very different one. So in this case, we have a 25-year-old woman, and this is another emergency department presentation, and she rocks up with a fever and headache. And they do a routine full blood count, which shows a significant thrombocytopenia of only 15 times 10 to the 9, which is really significant. And acute thrombocytopenia comes with a really wide differential. And there are only a few life-threatening causes. And amongst them would be things like acute leukemia, things like ITP. But given the presentation, the other thing that we might want to look at is something called a microangiopathic hemolytic anemia, which can come with a thrombocytopenia. And that's what this case is alluding to, because the lab call up and say the haematology registrar is on the way in to look at the film, but we think we can see something called schistocytes on the blood film. And this would... this is what they look like. There you can see these are, in case you don't know what a peripheral blood film looks like under the microscope, these, the red things here are all red cells, which are not looking in their classically normal way in any way, shape or form. You've got ones which are all burry, which are probably acanthocytes. You've got some schistocytes and some spherocytes in there as well, which don't have the central pallor. But you've also got these arrowed cells here, which are schistocytes or fragments, and they are literally red cells that have been sheared in half, which can come from a multiple array of causes. But this has some emergency differentials. The one that we're thinking about here is something called TTP, thrombotic thrombocytopenic purpura, which, if left untreated, has a mortality rate of around 90% within 48 hours. So we don't mess around when it comes to this one. There are some urgent investigations that we would send off, which I'll talk through in a second. But the mainstay of management is treating emergently. So this is one that the haematology registrar would be very, very interested in, want to be there to manage and transfer to an appropriate tertiary unit for appropriate treatment. Thank you, Ahmed. That's a really good point. DIC can present with thrombocytopenia and can present in this way and can present with fragments as well. But you would also have a clotting screen derangement. So that's why other investigations that would be useful here would be, one, to repeat your full blood count to make sure you're not missing anything, but do a clotting screen as well to make sure that we're not missing anything. But DIC you normally have more of a clue from the clotting parameters, but also you don't get quite so marked a thrombocytopenia. And given that this patient presented with fever and with headaches, it's alluding to this thing called TTP pentad, which is less useful because actually they don't all present with this, so it's a bit of a nebulous thing. But classically, you present with anemia, thrombocytopenia, and the underlying mechanism of this is basically, I'll go to the next slide to show you, this lack of an enzyme called Adams TS13, which in health allows very long thrombotic multimers of von Willebrand factor to be cleaved so that they don't end up in big clumps. And if you lose that deficiency, normally in the adult population, because you end up with an antibody attacking the enzyme, so you end up very, very low, or in children, you have a congenital deficiency, which is made worse by an acute sort of event like a bug or something else. You end up with these big plugs of uncleaved von Willebrand platelet thrombi, which clog up the very small capillaries. And when you've got that clogging up, the red cells can't get through and are literally torn in half. And those clumps can clog in the brain, in the kidneys, in the heart, the lungs, and elsewhere. And that's why it's life-threatening. So you want to get the diagnostic sent off for the quantification of the Adams TS13 enzyme, but also the antibody against it to confirm the diagnosis. You can manage this by managing the sort of underlying, sort of giving FFP, which contains some Adams TS13, and there is a recombinant Adams TS13 on the horizon. But the mainstay of management in current practice is very urgent plasma exchange, which basically means that you're going to put their blood through a machine to get rid of all of these clumps of everything else and replace with basically solvent detergent FFP back into circulation to basically increase the Adams TS13 assay and then go from there. And also, in the case of acquired TTP, start something like steroids and certain monoclonal antibodies, which I won't delve into now, but sort of more directed therapy to mitigate the underlying autoimmune the cause to try and increase this going forward. And we also give things like rituximab and things like that. But this is one of those things to be aware of that will have the haematology team coming running to the A&E to sort out and send off, because it is so life-threatening so quickly. But the differential is quite broad of a MAHA, including HELP syndrome in a pregnant lady, which is why a 25-year-old female is part of that case, to make sure you do a pregnancy test, making sure that you think about DIC, so looking at the clotting profile, making ssure you look at atypical HUS and atypical HUS as well, which goes in the same way. So renal function, things like that, are quite helpful to delineate. But yeah, the life-threatening thing there is TTP, and to be aware of that, understanding of MAHA and schistocytes and why that can be life-threatening. Moving on to our next case, case 3, which is a 27-year-old male who rocks up to the emergency department with fever and bruising. You might notice a trend here. And he has a bit of a pancytopenia. So just to be really clear about definitions, you have basically 3 lineages of cells: your red cells, your white cells, and your platelets. And they're the 3 lineages. And so you have a single cytopenia, which is just anemia, thrombocytopenia, or leukopenia. You have bicytopenia, which is 2 of those, and then pancytopenia, which is all 3 being suppressed. And you also have, in this case, a coagulopathy. And the lab call you up, say, again, the haematologist on the way in, but they think they can see blasts on the film. I'll give just 10 seconds for people to put in the chat. Does anyone have any clue what this case is hinting at as to a very concerning, life-threatening pathology that we would be wanting to treat very aggressively. It's absolutely fine not to know this. Okay, if there's no takers, I'm going to move on to so well done. So you're hinting there at using the acute leukemia. Absolutely. So acute leukemia is very likely in this circumstance, and it's very difficult sometimes to distinguish between myeloid and lymphoid without knowing that. There is a hint in this clue as to what we're hinting at as well, with the coagulopathy. So this is a blood film, and again we've got the so every lab has slightly different stains, so things can vary. But these cells, in comparison, these very stained cells are very large in comparison to the red cells around them. So these are very large cells, and if you look, they've got the nucleus, which has a very diffuse pattern. So there's no clumping of the chromatin within the nucleus, and there are some nucleoli where there's a bit of empty areas. And if you look at this middle cell, and so this is very clearly an immature cell, and so this is a blast, and it's got quite a specific morphology here, where you've got what's quite nicely termed as a buttock cell, where there's like a bilobed thing going on, and this cell in the middle has in the cytoplasm lots of rods. In fact, so many rods packed with our rods. Now, this is what they look like. And these bundles of rods here are pathognomic for a myeloid malignancy. And these cells, being the buttock cells with all these things, with a coagulopathy, is a particular type of acute myeloid leukemia, which is called acute promyelocytic leukemia, or APML, which is a very interesting subtype of myeloid leukemia, and is classically associated with Ahmed's earlier comment of disseminated intravascular coagulation. So the clue in the first question was there was a coagulopathy. Now, given that sometimes it takes a while to get the film looked at, if you suspect leukemia, one of the first questions the hematologist will ask you is there any coagulopathy? Because we're worried about this complication, okay? Because any leukemia can technically present with, coagulation derangements, but in this circumstance, APML pretty much always presents with DIC, and the APML has a really good long-term prognosis, talking 90-95% plus, and can sometimes be treated with, conventionally non-chemotherapy related things. But that prognosis only applies is if the patient survives the first 2 to 7 days, because the coagulopathy is the most likely thing to kill them. And you have to be really aggressive with coagulopathy management. So it's not that common. It's quite a rare one, but in 5 to 10% of young adults of myeloid leukemias are this one, and it's highest in the younger people. And it has this, just to help guide you, there are various ways of characterizing leukemia. That's normally, if you look on the right here, on where the cells have gone wrong in their differentiation from stem cells down to their professional cell at the end, the neutrophil or the other myeloid cell. And this one is the promyelocytic, so it's one of the progenitors that is a little bit after the sort of stem cell stage. And the morphology used to be termed sort of M1 to 7 based on where this differentiation point happened. That's gone a little bit out of favor, but you may see that terminology around, so it's just to explain that a little bit. It has a simple translocation, which is termed PML-RARA, which is basically the retinoic acid receptor. So the treatment is really interesting because this translocation basically stops the promyelocytes differentiating down the line. So we give them plenty of retinoic acid, which is all trans retinoic acid, or ATRA, and that allows the cells to rapidly differentiate, which comes with its own complications. But that can be life-saving very quickly, but can make the coagulopathy work. So what we're going to do is diagnose it with a blood film. We'll try and do a bone marrow if the coagulopathy will allow us. We'll get the rapid diagnostic, absolutely, Prasanna, treat with Atra, and get the rapid diagnostics to confirm the diagnosis, normally by real-time PCR, which can be turned around normally if you ask for it urgently within about 12 to 24 hours, depending on where you are. So we can get a diagnosis, but you're going to start aggressive treatment based on the morphology because it's diagnostic with that film we saw before. So yeah, as we said, so APML with DIC. So we're going to manage the DIC, which is the life-threatening complication here, which comes with a range of things. Now, DIC can happen secondary to all sorts of pathologies, okay? And what it basically means is, something quite nasty has happened within the circulation. One of my professors used to use the old adage, which you may have heard, which is DIC stands for death is coming, because it's such a life-threatening complication. And it can happen secondary to sepsis, it can happen secondary to malignancies, but most commonly infections or just being very, very poorly. And it's basically out of control hemostasis where there's consumption of all of the platelets and the clotting factors within one area. So there's uncontrolled clotting and doesn't leave anything left over elsewhere in the body. So they can have bleeding alongside it. Thankfully, they normally present with one or the other phenotype. But it can be very difficult to manage. And we often have to be very responsive to how the patient is clinically. But normally it's supportive care, so keeping the fibrinogen up because that's consumed very quickly, keeping the clotting screen non with sort of fresh frozen plasma, trying to keep the platelet count relatively normal. It's very common for people with with DIC, particularly with APML, to have subdural hemorrhages. So they can just one day say, I've got a slight headache, and you scan them, they've got a subdural hemorrhage. It's very difficult to manage that. So you're just trying to keep up with the product. So quite often they'll have 3 times a day clottings and full blood counts and regular products, and you have to manage the fluid overload, and it's difficult there. You also going to manage, they often present with fever, and you have to regard them as functionally immunosuppressed because they're going to have no neutrophils, so you have to manage them for neutropenic sepsis. And you're going to manage tumor lysis syndrome, which we'll come on to shortly, and we're also going to manage them for other complications. So in a nutshell, that's APML. DIC, basically, we've talked through. As Ahmed referred to earlier, we can get schistocytes in 30% of DIC, but it comes with quite a marked clotting derangement, which gives you the big clue what's going on. And there is a sort of DIC scoring template out there to help guide you, because it can be difficult to differentiate between them. But it's just trying to keep up with, the supportive care while you treat the underlying cause, basically. So that's how we treat that one. Does that make sense, I hope, for everyone? Right. If everyone's happy with that, and do interrupt with questions if you have them, we'll move on to case 4, which is our 40-year-old woman who presents again to the emergency department with fever, and this one has shortness of breath. And they do a full blood count, and she's anemic with a white cell count of 120, a platelet count of 35, and a chest X-ray is performed, which shows this appearance here. Now, I'll just give you 10 seconds in the chat. Does anyone have a spot diagnosis of what they think might be going on here in terms of the acute complication of a previously unknown patient to haematology? It is a little bit tricky, this one, because obviously there's a wide differential, but this chest X-ray shows quite, yeah, I think, good thought. There is definitely a bit of a menisci there, but I think that's actually just where the fissure is. This is, and this you can still see some lung markings on the right base. There may be a little effusion on the left there, but this is very marked infiltration, particularly on the lower bases, showing, this could be an infection or anything else. But given the very high white cell count, you're very worried about leukostasis here. Pneumonia is definitely one up there. But given the high white cell count, you're worried this is infiltration of those white cells into the lungs. And so you want to understand what's going on with this very high white cell count. And obviously you're going to treat them down various lines to make sure you understand what's going on. So this very high white cell count of 120 is the clue here. And so if you have that sort of level, like, more than 50, you have to start, and the short of breath, you have to think about this sort of thing. So you want to get a blood film to see what's going on. And this one will show a leukemia of some sort. And it's much more common in acute leukemias with those blasts as opposed to the chronic leukemias. Now, just to differentiate there, the acute leukemias are the differentiation point in them is normally the stem cell or the very early precursors where you present with these blasts, as opposed, and so because the stem cells rapidly replicate, the symptom onset is quite quick, which is why they're acute. Whereas the chronic leukemias are normally the professional cells, so stuff like the lymphocytes or the plasma cells or the neutrophils, which are replicating much more slowly. So that's why they're called chronic, because often the symptom onset is much more slowly progressive, much more indolent. And so that's a good way of understanding why they're acute versus chronic. And it comes to where the problem, the differentiation tree has come from to lead to that increased cell production. And blasts are, as we saw before, big cells, and particularly myeloid cells, big and sticky. And so they will clump and cause, congestion wherever they are. There are actually problems that you can get with any cell line being increased. So if you have a very elevated red cell, if you have that's polycythemia with the very raised hematocrit, you can end up with hyperviscosity. If you have a very elevated platelet count, so a thrombocytosis, they can also come together, giving you some other problems with clotting, but obviously they're very small, so you don't really get sort of viscous symptoms. And if you have problems with lymphocytes, which produce antibodies, so stuff like immunoglobulin producing lymphoproliferative disorders or particularly myeloma, that can present with very, very high levels of immunoglobulin, which can also cause hyperviscosity symptoms. And that basically means that there is sluggish flow. And if there's lots of leukostasis, you get a similar picture where wherever there are small vessels, you will not get good flow, and therefore you'll get an element of ischemia. So you can end up with cerebrovascular accidents, confusion, without clear evidence of infarct, headaches. You can end up with pulmonary complications, so dyspnea, respiratory alkalosis. You can end up with cardiological implications, so angina and even MIs. So there's a wide array of ways that hyperleukocytosis can lead to symptoms, and that when you are symptomatic, you have leukostasis. It's most common when you have a white cell count more than 100, but it can occur at lower levels. So have a low index of suspicion for this, and the way forward is to try and dilute things down to allow better flow. So fluid, like aggressive fluid management. Sometimes we'll do something called leukapheresis, which is similar to the plasma exchange, where you're going to try and, basically put them through what is effectively an apheresis machine to try and spin off some of those white cells and then put back the stuff that you want into circulation. But the mainstay of management is treating the underlying cause. So that's cytoreduction. So you're either going to give definitive chemotherapy if it's acute myeloid leukemia, But sometimes if you're struggling, you might give something like a hydroxycarbamide, which is a sort of a global myelosuppressive, just to bring the count down to reduce symptoms. But it depends on the underlying cause, so that needs evaluation by the haematology team. It's a bad sign. If you have leukostasis, your mortality is, close to 50% normally within a week. So it needs urgent treatment, not least because it can kill them of itself, but it's also a sign that the underlying cause is quite marked and can be a later sign. It doesn't occur very commonly, but when it does, it can be quite scary because it takes quite a lot of aggressive management to get things under control, and you're managing not only the complications, but the problems of therapy. So fluid overload, their hearts may be in difficulty and they're struggling with a reduced ejection fraction. It can be very tricky. You've put some very good thoughts in your thing there in terms of pleural effusion, because it does look very congested. And you might well do a CT just to evaluate that, because if there's something to drain off to help them breathe better, if they're really tachypneic in oxygen and you want to drain something off, they will end up with malignant effusions as well. So sometimes that can be helpful, and you will be treating them for pneumonia concomitantly. But this is what this case was driving at, this overall picture of leukostasis, which is quite a scary complication. Right, case 5. So, 60-year-old bloke, and the medical team are fast bleeped to review at 3 in the morning on the ward, following a fall or a Sickle episode. It's not entirely clear. And I've done these points in the wrong order. I do apologise. He's been recently started on chemotherapy for bulky DLBCL, which stands for diffuse large B-cell lymphoma. This is one of the high-grade lymphomas that we had in case 1. And bulky means that it's big. It normally means more than a lymphadenopatous mass of around 7 to 10 centimeters. So it's a big mass of tumor. And he's got a background at the age of 60 of a bit of chronic kidney disease, but bloods are done urgently, and he's off his baseline. He's got an AKI. His potassium is silly high, and also his calcium has dropped massively. And when you examine him as well, he's got a tachycardia, and someone's flailing around for an ECG machine to try and evaluate what's going on. Does anyone have any thoughts about what we might be dealing with here? Spot on, Stephanie. TLS, tumor lysis syndrome. Depending on where you work, sometimes emergency therapy needs to be started in non sort of hematological context, or sometimes if there's very bulky disease, tumor lysis can even be a presentation symptom and presentation of some bulky disease where there's autolysis. So what we're getting at here, so these are the questions I had: what's the differential, what are you most concerned about, and prediction of who might get this, and treatment. So we'll go through that now. So it can happen in a range of malignancies, but it is most common in high-grade hematological cancers, because there is quite a lot of tumor burden. And when you lyse a cancer cell, most commonly acute lymphocytic leukemia, high-grade lymphoma, such as Burkitt's or diffuse large B, particularly if you've got a big disease burden, so bulky disease, then those cells get destroyed, either by autolysis. So if you've got a big mass that suddenly, because it's got very poor angiogenesis, so the blood vessel formation is pretty shocking, then some of those cells, some of those parts of that bulky mass will just die because they're not well perfused, and then you get release of all the cellular contents, which includes all the DNA metabolites and purines and everything else. Your phosphate, your potassium, and all the cytokines as well will all be released into the circulation. And that can happen after chemotherapy as well, particularly in someone who isn't able to clear those very well. So if you've got underlying renal impairment, and most people who are a bit more elderly, so if you're 70 and you've got this, then you would be a much higher risk. So if you had a 70-year-old with CKD, bulky mass, you'd be sat there going, oh my God, you're going to get something, and you'd do everything you can to try and risk mitigate that. And there's various mechanisms by which it happens. So, everything gets, all those purine metabolites get broken down into uric acid. And it can be quite difficult to excrete that because uric acid requires functioning kidneys and urinary excretion. And if you've got a lot of it, or you've got poorly functioning kidneys, you're going to get overwhelmed. And if the kidneys aren't clearing stuff, and you get basically uric acid crystal formulation, and then that potentiates phosphate crystal deposition in the renal tubules as well, and you get a burden of potassium as well. So you end up in significant dysrhythmias. So they can go into VT, and it can be terrifying. And that can then make the AKI worse, and that can lead to other sort of deterioration of fluid status and poorly functioning. So it's a very scary thing when it happens. Some of the things that we can use to mitigate it is something like allopurinol, which is xanthine oxidase inhibitor, and basically doesn't allow xanthine to be changed into uric acid, which means it can be just basically you can just clear it from the blood a bit more quickly. Or you can use something called resburicase, which converts uric acid into allantoin, which we don't, is a step that some mammals have but humans don't, to help clear it off a bit quicker and basically turn it into something that won't clog up the kidneys effectively. So resburicase can be used as a prophylactic measure and can be used as a rescue modality as well. And we have two ways of defining tumor lysis. One is basically on lab criteria, so they're clinically well, but the urate goes up, the potassium goes up, the phosphate goes up, and the calcium drops because it crystallizes out of circulation. And then you have clinical TLS. And if you're in that situation, your patient's overall prognosis is bad. You need to be on top of this quickly, and not least because it's, AKI, cardiac arrhythmia, seizure, or death, is a fairly catastrophic event here. And so if you have that situation where they're going to clinical TLS, you're going to be chatting to ITU to get them on the filter to try and clear this off, and to get that potassium under control, get the uric acid off, get them on resburicase, and try and balance this. But mortality is very high if they end up there. The identification of those who are higher risk has meant that they can be pre-phased with allopurinol, which takes 24 hours to work, or given prophylactic resburicase or rescue resburicase to rescue the situation. So our mortality from TLS is actually much less than it was 20 years ago. But it still happens, and it can be very rapid. And you can have a completely well individual who starts chemotherapy and is dead within 12 hours. It can be that quick. So quite often, after starting a high-risk regimen, you'll be doing bloods, 4 hours afterwards, after a baseline, and then every 3 times a day, twice a day, depending on the risk, to just make sure you're not missing it and being aggressive with fluid management. So it can be quite a scary complication if you're not careful. Right. Case 6, which is our last case. So if I haven't covered something that you've seen in the past, then do start thinking about it now. Because this is a 19-year-old man with known HBSS, which is a homozygote for sickle cell. Okay, so this is sickle cell disease, and they're on a regular transfusion program, showing they're quite severe. They're on HU, hydroxyurea, also known as hydroxycarbamide, to try and increase their hemoglobin F and to keep their complication rate down. So this automatically is saying this is a high-risk individual. They're on iron chelation therapy because they're on the regular transfusion program, so their iron burden may well be very high. They're on the appropriate prophylaxis with penicillin and some folic acid, which is of dubious merit. And they come in presenting with a 1-week history of generalized pain, and it's not responding to regular oral analgesia at home, and it's getting worse in the right arm and in the rib. They're completely, without fever. Their heart rate's 96, their blood pressure's good, their respiratory rate's 24, SAT's 92 in room air, and some right basal crackles. Okay, so Eniola has done a really good leap here. So yes, this is ostensibly a VOD, a VOC, a vaso-occlusive crisis, or vaso-occlusive disease with the pain, with some early signs of evolving acute chest syndrome. And this patient, so you can tell this is an uploaded PDF because this was meant to evolve over time. So the initial management here is, make sure that they've got appropriate pain relief. You'd want to make sure that they're in appropriate oxygen and have very regular OBS. You'd want to make sure you understand their underlying disease. So you want to make sure they have an urgent full blood count, group and save, and highlight to the transfusion lab that you've got a Sickler in, because particularly on the transfusion program, they're very likely to have allo antibodies. So antibodies complicating giving a safe cross match. And if they're going to need transfusion or exchange, you want to know what's going on there. You're going to be looking at their liver function, their renal function. You're going to be looking at their infection markers, and you'll also be thinking about their sickle percentage as well to think about, whether you might need to do something there. And you're going to be doing some very sensible risk mitigation, so regular observations, particularly because you're going to be giving them opiates, which will give them respiratory depression, and they may obtund them as well. So you want to be observing these guys like 1 to 2 hourly. And there is some signs here that they're not breathing very well, and that may be just the fact they've got some pain in their rib and they're just not breathing very much, but it could be something else. So you're going to be wanting to get a chest X-ray, and you review them 5 hours later. The chest pain's awful, and they've dropped their SATs to 80% in room air, respirates up to 33, and you've got the chest X-ray back, and it shows an infiltrate, so a left basal pneumonia and some interstitial shadowing. You do an urgent ABG, and it's just awful. You've got you've got hypoxia, and you've got a little bit of borderline high raised CO2, and this is bad. Okay, this is an emergency, and the reason for that is this thing called acute chest syndrome. Okay, and this is a really simple diagnosis. People always overcomplicate it. It's basically an acute illness in a sickle cell person with fever or respiratory symptoms, one or the other, and radiological evidence of infiltrate. That's it. Okay, they may not be very bad. There's obviously severity markers, and the literature is mixed. But if they're hypoxic, it's bad. The mortality rates vary, with between 3 and 10% mortality for each admission with acute chest syndrome, and 1 in 5 need to go to level 3 intensive care with ventilation. So this is something that you need to escalate quickly, and it can be the way that people present. So they come in breathless, and you get the X-ray, and you're like, Jesus, and you put them on oxygen, and you're going to give them intensive spirometry and everything else. It can be when they've been in for a few days, because they've had a vaso-occlusive crisis, they've got pain, which means they're not breathing very well. And this comes down to the underlying mechanism of sickle cell disease. You get an initial insult, whether that be, hypoperfusion or infection or infarction, and you get reduced oxygen in the chest, which leads to HBS polymerization, reduced pulmonary blood flow, more vaso-occlusion, more hypoxia, more polymerization, and a big vicious spiral. And these individuals can deteriorate so rapidly. You can have someone who's completely well at 8 o'clock in the morning and needing intubation by midday, if not sooner, because this process happens so quickly. So that's why, if you've got someone who's high risk, chest crisis affecting their ventilation, they're on high opiates, reasons for respiratory depression, obtunding, not breathing very well, infection on board, signs of fever or breathlessness, you want to be aggressive. You're going to be wanting to involve appropriate professionals. So you want to make sure that you examine them regularly, get the haematologist involved, get the outreach team involved, get the ITU teams involved, give them their prophylaxis because you don't want them having a PE to make all this process worse. Hydrate them, get them to euvolemia, but hydrate them aggressively. Give them antibiotics because it could be a consequence of infection. Make sure they're pain free. Get chest physios involved, and if necessary, give them a top-up transfusion, which is obviously based on their transfusion history and everything else. But you need to be quite alert to these patients because they can deteriorate so quickly. It can be really scary, and that's why I wanted to highlight this. If you have a patient who is affected by sickle cell disease, most of the time, if they come in with a simple vaso-occlusive crisis, it can be quite easily managed with good analgesia, good recognition, and good supportive care, and it won't deteriorate. If you're not careful, things can quite quickly get worse. So just being vigilant is what I want to highlight there. Okay, those were my 6 cases, and we got quite close to the hour time, so not too bad, I hope. This was the QR code for feedback, so if you have anything you would like to feedback, that'd be appreciated. But I would really like to invite you to ask any questions, or if you've got any interesting cases that you think are relevant here, I would be very happy to chat about them.
James, just as we're waiting for questions to come through the chat, I just want to say thank you so much. That was really, I really enjoyed it, and I'm sure that the rest of people listening did too.
Thank you. You're welcome. If you don't want to put any cases in this forum, please feel free to email me if you want to. I'm always happy to respond if there's something that you wanted to know. Okay. It's a very big question. As I said at the beginning, hematology is one of those topics that, because it's a relatively low yield question in the exams and everything else for medical school, most people don't really know about it for anything. So it becomes a bit of a black box for many people throughout medicine. So I think the most important things to know about, they won't be expecting very much, I promise you. We get, junior registrars and all sorts coming through who genuinely, know the basics, and that's completely fine. If you're on the ward, particularly on a malignant ward, you will get involved in the malignant side of things. So that'd be the lymphoma side, the sort of acute leukemia side, and you'll learn a lot about the complications and about the management of patients on the ward. What you won't get really, unless you go to clinic, is some of the common hematological questions which you won't really appear on the hematological wards. So how to look up and investigate an anemia or a thrombocytopenia, how to do the basic workup. And so that would be something you wouldn't necessarily have to brush up on, but see if you can get your registrars and consultants to go through those topics. That will be more useful to you if, by some bizarre, weird coincidence, you don't end up becoming completely enamored with hematology, will become useful for whatever career you end up going into, because hematology touches on everything else. So I think learn on the ward, just be engaged, but try and get them to talk about things that you might get if you're elsewhere in GP land or in paediatrics or in acute med or surgery. How to manage those. What order are you giving treatment in DIC? It's a very responsive thing there, Stephanie. You basically give what you need to. And quite often you will give them, if they're very, very thrombocytopenic, you will give them platelets to maintain their platelet count above 50 if they're bleeding. If they're not bleeding, you probably won't give them platelets because you don't want to make it worse. And you definitely would avoid platelets in TTP. So you want to be confirmed with the diagnosis. FFP is normally the mainstay of management because they end up with more significant a coagulopathy than they do a thrombocytopenia most commonly. But it's very variable. So you are responsive to the individual. Okay. I think that might be it.
Yeah, fantastic. Thank you so much. Oh, any questions?
In critically ill patients that aren't bleeding, it's always on a case-by-case basis. On the whole, if they're ill, they're going to be at high risk of thrombosis. So unless there are reasons not to, the answer is yes. If they're so ill that they're bedbound and highly inflamed and everything else, then yes, you're going to be giving thromboprophylaxis. The only caveat to that is if they're bleeding, if they're very thrombocytopenic or they've got some sort of bleeding diathesis, so you're seeing either coagulopathy in the blood work or in other parameters that would be giving you thought that they might bleed, you will be giving them VTE prophylaxis, yes. So the default is yes, unless there are reasons not to. You're welcome. You'll all be fine. Don't worry.
I'm sure we can let you go now. Thank you very much, James.
Oh, cool. Happy to do it. See you later.